Welcome to the ISAM ASAM symposium that we have every year. And as many of you may know, ISAM actually started from ASAM, the American Society of Addiction Medicine. And we have several people from ASAM here, I see, in the audience. But the theme this year we chose was opiates and stimulants, because those are the scourge of the West and the East, actually, around the globe. So opiates and stimulants was the theme of this year's ISAM ASAM symposium. And we have a great panel. We have Marc Potenza, who is the president-elect of ISAM, and he's going to be talking. And then we have Steve Taylor, the president of ASAM. So Steve, big hand. And I'm Greg Bunt, a past president of ISAM, and we also have the inimitable Kathleen Brady, who is a past president of ISAM and the only woman president. So let's have a big round of applause for Kathleen Brady. And she always serves as a great, refreshing, moderating force on these panels, particularly when the rest of us are men, and she has a refreshing woman's touch. So I think this will be a great symposium. And so without further ado, I'm going to turn it over to Marc Potenza.
So thank you. And thank you for the introduction. So in prior years, for the ISAM ASAM symposium, we have discussed the ways in which ISAM and ASAM have worked together. And while we are still doing that, we thought for this year we would present data on some of the pressing problems that societies share around the globe with respect to several classes of substances, particularly stimulants and opioids. So I'll be talking about stimulants and opioids from multiple perspectives, including from public health, neuroscience, as well as treatment, development, and implementation. So I have a listing of disclosures with respect to pharmaceutical companies, as well as gambling, gaming, nonprofit, healthcare, and legal entities. And thought I would think about opioids from historical perspective to begin with. We heard from Professor Rem that opioids have been a concern, as well as other substances, have been concerns dating back millennia. And in the United States, there were significant concerns raised about opium dens in the 1800s. And later, during the 1960s and 70s, there were significant concerns about, in the Vietnam era conflict, about US military forces becoming addicted to opiates. And it was estimated that about 10% of the military had problems with opioids back at that time. And this in part led the government in the United States. They were very concerned about what was going to happen when this group came back, and this in part led to the organization of NIDA through the National Institutes of Health. Currently, or in the past decade or two, the prevalence estimates of opioid use disorder have ranged from less than 1% to 4%, depending on the methodology of the surveys. So while it is not necessarily the most prevalent condition, it is a very impactful condition in many ways. One of the ways in which it is impactful is with respect to overdose deaths. While stimulants may generate one intoxication and withdrawal symptom pattern, opioids, while the withdrawal symptoms are particularly uncomfortable, it's the intoxication that can be fatal because it shuts down respiratory centers. And what we have seen during the past 25 years in the United States has been an opioid epidemic that has had multiple waves. And what we're looking at here are data from over 20 years looking at overdose deaths in the United States by gender. And one can see that for both males and females over the course of a 20-plus year period, the number of overdose deaths has been increasing, particularly for males. And then if we look at this, that was for drug overdose. If we look at this specifically for opioids, we see a similar trajectory, but then particularly in from 2015 on, we see this steep increase in overdose deaths involving any opioids, rising for both males and females, but particularly for males. And it was estimated that in 2021, 45 people a day in the United States died from a prescription opioid overdose. So these waves of opioid overdose deaths appeared to initiate with the promotion of prescription pain medications like OxyContin that were being purported to be less or non-addictive, and then led to people having problems with opioids. Then subsequently moving into a phase where heroin was being introduced with subsequent to prescription pain medication. And then other synthetic opioids, particularly fentanyl, which is very potent, and people may have more difficulty gauging the amount that they are self-dosing, and perhaps leading to more overdoses. And then what we can see is with respect to the overdose deaths involving prescription opioids, we do see again this rise, but perhaps an earlier plateau given the different waves of the opioid epidemic in the United States. So given the rise in using fentanyl, we have recently looked at data from the 2022 National Survey on Drug Use and Health, and we investigated the individuals who reported use of illegally manufactured fentanyl. And while the prevalence of using illegally manufactured fentanyl was low, it was 0.78% among men and 0.44% among women, we found that there were specific groups that may be more vulnerable to using illegally manufactured fentanyl. And these tended to be males, who were in a young to middle-aged age group from the 20s to the 40s, individuals who were poor, less well-educated, and unmarried, as well as those having physical and mental health concerns. And this group also more frequently reported having easy access to heroin. So this link with other opioids is salient in those data. Now, there has been described what is the fourth wave of the opioid overdose crisis in the United States, that we have seen the introduction of stimulants with opioids. This combination is historical, speedballing, chasing the dragon. These are terms that have been applied historically to the combination of using opioids and stimulants. In the United States, more recently, what has been seen has been this rise in the stimulant combination with synthetic opioids in overdose deaths. So we were also interested in understanding how young these patterns of co-use occurred. And so we used data from the 2019 Youth Risk Survey in Connecticut to look at youth who reported prescription pain medication misuse with and without heroin use. And we found that 8.8% of the high school students reported prescription pain medication misuse, and 1.4% reported this combination of prescription pain medication misuse and heroin use. And both groups demonstrated more concerns, and particularly this latter group with the co-use, particularly with respect to the use of other substances and with respect to mental health concerns, including suicidality. So some of those data are shown here with respect to the groups of without prescription pain medication misuse and without heroin use, the group with only the prescription pain medication misuse, and the group with the prescription pain medication misuse and heroin use. And one can see that there are significant differences with respect to reports of having access to drugs at school, use of electronic vaping devices at school to use substances, and then the use of alcohol, cannabis, and other illicit substances. Some of these are found both with respect to the prescription pain medication misuse, independent of heroin use, but for some of the substance use, the co-use of prescription pain medications, heroin, and other substances seems particularly robust. Now we also, and I apologize, this may be a little small to read, but this is with some mental health concerns with respect to between group differences, and looking here now at adjusted odds ratios, comparing the prescription pain medication misuse versus not, the group with both prescription pain medication misuse and heroin use versus the non-using group, and then looking at the difference between the prescription pain medication misuse with heroin use versus without. And if we look at that far right column, some of the differences linked to the co-use of prescription pain medications in a misusing fashion and heroin use appear to be with respect to suicidality, with respect to attempted suicides, considering suicide, as well as with attempting self-harm. So it raises questions then about what about treatment. And Yale has a long-standing psychotherapy development center where we have tested and randomized clinical trials different interventions, including for individuals with co-occurring stimulant use problems, particularly cocaine use disorder and opioid use disorder in individuals who are in treatment at a methadone clinic. So we've also been interested in understanding the brain mechanisms that underlie the differences linked to cocaine use disorder, opioid use disorder, their co-occurrence, as well as how we might best help people with these co-occurring concerns. So if we think about addictions, there have been multiple models that have been advanced for why people might develop addictions. One prominent model is a dual process model where motivational drive is particularly robust for engaging in the substance use or addictive behaviors, and then cortical control is relatively diminished over these motivational drives, leading to excessive or problematic engagement. So in testing a dual process, within a dual process framework, we have utilized several functional magnetic resonance imaging, or fMRI, tasks. One that looks at cognitive control, the Stroop color word interference task, and one that looks at reward processing. In this case, a learned reward, monetary rewards. And the monetary incentive delay task is a task that has been developed and used for over the past 20 years. And so given that people have gathered considerable data with the monetary incentive delay task, we and other groups. And one of the more consistent findings that exists for substance use disorders as well as addictive behaviors like gambling disorder is that individuals with addictions, substance use disorders or gambling disorder, tend to show a less robust activation of the ventral striatum during the anticipatory phase of reward processing. And so the three images on your left are from a meta-analysis by Marc Potenza, which utilizes data from our groups and other groups to identify this shared blunted ventral striatal activation. And this fits within a reward deficiency hypothesis that Ken Blum and others have proposed, whereby individuals with addictive disorders tend to show less robust activation to non-addiction rewards. Perhaps they have the misdirected motivation towards the focus of the addiction. It also appears to extend to internet gaming disorder, although these are data from an independent study using a separate task. So what about opioid use disorder and co-occurring cocaine use disorder and opioid use disorder? So we were interested in reward processing in this group, or these three groups. The HC is the healthy control, CD is the cocaine use disorder, and the CDMM is the cocaine use disorder on methadone maintenance. And in this sample that included individuals without addictions, those with cocaine use disorder, and those with co-occurring cocaine use disorder on methadone maintenance, we do see a between group difference, a main effective diagnostic group during the anticipatory phase of reward processing that implicated frontal cortical as well as visual processing regions, where the group with cocaine use disorder and co-occurring opioid use disorder on methadone maintenance tend to show the most blunted response. We did see relationships with methadone dose, which may suggest that there are effects of methadone that are important to consider. And then we also looked at relationships between activation, particularly during reward processing or loss processing, where striatal activation was linked to maximum days of consecutive abstinence. More recently, we have looked at the cognitive control-related data, and we've looked over time at changes in brain activation patterns in a group with co-occurring cocaine use disorder and opioid use disorder, and looked at before and after treatment, as well as a healthy control group test-retest data. And what we saw was that there was a main effect of time in the overall sample that involved less striatal activation post-treatment as compared to pre-treatment. And this seemed to be particularly related to the treatment-engaged sample of the group with cocaine use disorder and co-occurring opioid use disorder. However, how the brain works, we believe, and I think others as well, is that the brain regions are not activating in isolation, but rather in networks. So we have a group at Yale has developed a process called connectome-based predictive modeling. And looking at, we have used this approach to look at whether we can predict cocaine abstinence in a group of individuals with cocaine use disorder. So connectome-based predictive modeling is a machine learning approach. It uses a leave one out cross-validation methodology to protect against overfitting of models, and it allows one-to-one mapping back to brain anatomy. So we were interested in looking at whether we could predict cocaine abstinence using this approach. And these data, which were now published about 5 to 6 years ago in the American Journal of Psychiatry, indicated that both with the positive network and the negative network, we could predict greater than chance the connectome, the patterns of connectivity that were linked to positive and negative that were linked to abstinence in the cocaine use disorder sample. And if we looked at the brain regions that were most highly connected, that were predictive of the cocaine abstinence, we can use different thresholds to identify the different brain regions' connectivity patterns. So for example, if we look at the far right and we use a threshold of 12 or more edges, we see that corticolimbic connectivity patterns are among those that are contributing to this connectome-based prediction of abstinence. Now, there are canonical networks, brain networks, that have been identified that operate across individuals. So we can take these data and divide them into brain networks and look at between network patterns of connectivity. So these maps that look at either on the far left, the positive network, in the middle, the negative network, and then the positive minus negative, can provide insight into the ways in which the networks operate to predict abstinence in this instance. So for example, if we look at the top left, we see that the relationship, the stronger positive relationship between the frontal parietal network and the medial frontal network is contributing to the prediction of cocaine abstinence. And by looking at these maps, we can then generate models to look at between network integration and segregation to predict abstinence. And then we can use our knowledge of these networks and how they are involved in other processes to propose models as to how a coordination of salience and encoding and reward processing, looking at the bottom networks, and how they are segregated from coordination of attention and executive control might be predictive of cocaine abstinence. So again, thinking about then opioids, we were interested in then understanding the extent to which opioid abstinence might be predicted from the data. So we looked at the sample with co-occurring cocaine use disorder and opioid use disorder, and we found that we could predict an opioid abstinence network, but this was significantly different from that predicted cocaine abstinence. So for the opioid network, there was stronger within network motor sensory connectivity and reduced connectivity between motor sensory network and medial frontal default mode and frontal parietal networks. The take-home from this is that there are distinct brain networks that are predictive of cocaine abstinence and opioid abstinence, suggesting that there might be different interventions that might be helpful for people. And if we looked at the data, because we collected from the samples the cognitive control, the reward processing, and the resting state data, we found that if we independently looked at the prediction models, for opioids, the cognitive control task data were the most robust. For cocaine, the reward processing task was the most robust. But if we took the network that was identified on the cognitive control task for opioid abstinence, we found that it then went across the other data, the reward processing and resting state data. But if we looked at the extent to which the identified cocaine abstinence network predicted opioid abstinence, it did not function, did not reach significance for cocaine abstinence. So these networks functioned independently is the take-home from these data analyses. Additionally, if we lesioned one of the networks, we still found significant results for the predicted versus actual opioid abstinence, suggesting that this is a robust model. So in many ways, this leaves us more questions, but it helps us perhaps identify potential network targets that could be considered for example, non-invasive neuromodulation in the future. So in conclusion, opioid use disorder is a major public health concern, with overdoses being particularly concerning. And more recently in the United States, there's been a co-occurrence of stimulant and opioid overdoses. Among developing youth, problematic prescription pain medication misuse and heroin use are linked to other substance use and mental health concerns, suggesting that we need to intervene early in time and consider these multiple domains to help youth develop in a healthy fashion. Among adults, illegal fentanyl medication misuse was particularly prevalent among certain groups of individuals that suggest that there may be this aspect of despair or lack of hope that needs to be targeted in specific groups in order to help individuals with multiple substance use concerns. And then the brain imaging findings suggest that we may need to consider different treatments to help promote cocaine abstinence versus opioid abstinence. And I'd like to thank a large number of individuals, funding organizations, and thank you for your attention.
Good morning, everyone. I have the pleasure of introducing Dr. Stephen Taylor. Dr. Taylor is a graduate of some of the most prestigious institutions in the United States, both Harvard University and Howard University. He is the current president of ASAM, the American Society of Addiction Medicine. He's a triple threat, board certified in psychiatry, child and adolescent psychiatry, as well as addiction medicine. He has 30+ years of experience in treatment, teaching, training, and advocacy in the area of substance use disorders, and he has served as the National Director for Addiction Services for the National Basketball League in the United States, which is an extremely prestigious position. He's going to talk to us today, just give us some basics about stimulant and opioid use disorder. Thank you so much.
Thank you, Dr. Brady. We're going to get my slides together here. I'll start out with just acknowledging the intriguing presentation by my co-presenter, Dr. Potenza. While he is an academic with a gazillion publications and many years of experience on the faculty at Yale, I am a clinician. And so I'm going to be talking about a much more clinical approach to this topic, looking at just treatment issues and some of the issues that we are dealing with in the United States, and some touching somewhat on some of what goes on around the world as well. So treating patients with co-occurring addiction to opioids and stimulants is what I'm going to really focus on. I have no disclosures. And the learning objectives, just briefly, we're going to consider some of the epidemiology of opioid use disorder and stimulant use disorder in the U.S. We're going to understand some key principles for treating patients with co-occurring opioid use disorder and stimulant use disorder. We're going to perform or be able to perform basic screening and an initial assessment for patients with OUD and stimulant use disorder, and then talk a little bit about some of the concepts of treatment of patients with addiction to opioids and stimulants. And I'm going to focus also a little bit on some of the hot button issues that we at ASAM have been trying to address in the United States regarding specifically treatment of opioid use disorder. So starting out a little bit of epidemiology, but from 1999 to 2021, almost 645,000 people died from an overdose involving any opioid in the United States, and that includes prescription and illicit opioids. In 2022 alone, over 100,000 people died from an overdose. And over 75% of those deaths involved an opioid. Now, some of you who have been following the news are aware that we've just gotten new data out that has demonstrated that there is a decrease, finally, in the numbers of people dying from opioid overdoses or from drug overdoses in the United States. That number is estimated to be around 73,000 people who died. So I would hasten to say that while that is clearly an improvement and the first time we've seen a decrease in a couple of decades, we are nowhere near out of the woods. We're nowhere near where we need to be with respect to the overdose crisis in the United States. So a little bit about opioid addiction. Obviously, it impacts individuals from every demographic and socioeconomic group, but not necessarily, at least in terms of this opioid crisis, not necessarily equally in all populations. And I'll just show you a slide that highlights that. Overdoses are the leading cause of accidental death in the United States, with opioids being the most common drug, particularly fentanyl, as Dr. Potenza talked about. Overdose deaths contributed to declining overall life expectancy in the United States. The social costs of OUD and fatal overdose were over $1 trillion in 2017, and increased deaths from polysubstance and rising racial disparities in fatal and non-fatal overdoses have actually characterized recent years, and I'm going to talk very briefly about that. You heard Dr. Potenza talk about the 4 different waves of the overdose crisis, and he showed this slide. Just important to point out that the rise in stimulants really started in 2015, when we saw a significant rise in overdose deaths that involved fentanyl and stimulants, and I think he highlighted some of that earlier. I'm not going to spend a lot of time on that. Stimulants are the second most common drug class contaminated by fentanyl, and so one of the most common ways that people who are using stimulants end up in an overdose situation is because they're not actually aware in many cases that the stimulant they're taking also includes an opioid. And you can see some of the data shown here in terms of the overdose deaths with different drugs. This is a slide on past year CNS stimulant misuse among people 12 and older in 2023. And you can see the largest number of people used cocaine only, but then there was also cocaine and prescription stimulant misuse that was common. And then you see in yellow the prescription stimulant misuse only. and then cocaine and methamphetamine and the different combinations that you see depicted in this slide. Altogether, 9.7 million people aged 12 or older had reported past year stimulant misuse in 2023. This is a slide that looks at 12-month ending provisional number of drug overdose deaths by drug or drug class, again, in the United States. And as you can see at the end, there is, as of January 2024, beginning to be this decline in the overdose deaths. But again, just be aware that the largest group still is a group that has stimulants with abuse potential, but also with opioids. Oops. The current wave is characterized by polysubstance use. And polysubstance use, Dr. Potenza highlighted a little bit about speedballing and the use of stimulants intentionally to try to wake people up from their CNS depression from opioids, or to calm people down from the excitatory effect of stimulants. But the phenomenon that we're experiencing in the U.S. In recent years has been much more of a problem of drug use, polydrug use, that people aren't necessarily aware of. Folks don't necessarily know what they are getting when they're using substances in the U.S. And so that is part of what you see reflected in these statistics, particularly in the latter years where you see those increases. This is drug use by state. Interestingly enough, our immediate past president of ASAM, Dr. Brian Hurley, likes to share this story about his own career, where he went to medical school in Boston. And in Boston, for the 4 years that he 4 months that he was there, I'm messing up the story. 4 years that he was in medical school, 2 years doing the clinical rotations, he saw a grand total of 4 patients with methamphetamine use as their primary drug problem. He then moved to California and started working in California in an emergency department, and in the first few hours of his first shift in the emergency department, he saw more than 4 patients with methamphetamine use. And so the differences from different parts of the country in terms of what substances people use are displayed here, with cocaine being much more prevalent up in the Northeast, and then methamphetamine being more prevalent in the West and Midwestern parts of the United States. As is always important for us to remember, co-occurring substance use and mental health disorders are common, need to be evaluated carefully, and need to be treated in a coordinated and integrated fashion as much as possible. I have always felt like it's important to make sure that we include some of this data. So 84.5 million adults had either a mental illness with or without with or without serious mental illness or substance use disorder. And so this is data from SAMHSA from 2024. All right. This is what I was talking about in terms of some of the differences, and what I think was interesting, even during the pandemic, when we were all focused and had been focused for quite some time on opioid use disorder and the opioid overdose deaths that were occurring, what began to become evident was that in Black communities in the United States, it was actually deaths from stimulants that were a greater cause of overdose deaths in black communities. And so you see on the left, cocaine and opioids, 575% increase in black persons, 184% increase in white persons when it comes to cocaine and opioids. And here with methamphetamine and other stimulants, 16,200% increase in black persons as opposed to a 3,200% increase among white persons. So the stimulants were much more popular in black communities in the United States. The other thing that happened during the pandemic was there was a spike in overdose deaths from in black communities, such that at that point, for the first time in the overdose crisis, the numbers of overdose deaths overall among black communities surpassed the numbers that were occurring in white communities. And prior to that, the overdose crisis in the U.S. had been understood as primarily a problem among rural white populations, and that was sort of the prototypical demographic of people who were dying from overdoses, and not a lot of attention was paid to other communities, particularly what was going on in black communities. And so this was secretly happening, in a sense, the fact that black folks were much more likely to be succumbing to stimulant use along with opioid use. And then also, once the pandemic hit, that actually caused the change in the predominance of overdose deaths. Fentanyl, as I said before, so often people in the U.S. who are dying from overdoses don't actually know what they're taking. There's this phenomenon of fentanyl disguised as other drugs that was linked to the spike in overdose deaths. And you see here real Xanax versus counterfeit Xanax on the left. Fentanyl-contaminated cocaine in the middle, and then fentanyl-contaminated hydrocodone. The old movie Forrest Gump has a line in it where he says, life is like a box of chocolates. You never know what you're going to get. And that's been very true among the folks who use substances in the United States. People really do not know what they're using, and that's been a major contributor to some of the overdose deaths in the U.S. Again, yet another ingredient, contaminant that has contributed to the overdose crisis in the U.S. Xylazine, which is a non-opioid sedative with analgesic and muscle relaxant properties, and it was used as a veterinary tranquilizer, and it acts as a central alpha-2 adrenergic receptor agonist. But in fact, it's been on the street for a number of years in different specific communities, has its own nickname of Trank, and there's this increased prevalence of xylazine that was found in a lot of opioid overdose situations, such that it made the overdose reversal efforts much more complicated. People described very complicated withdrawal symptoms, and then the sort of characteristic famous necrotizing skin wounds would be observed in a lot of these patients when they present to the emergency department. Some key principles that I think are important about taking care of folks who have opioid use disorder and stimulant use disorder is that as we've talked so much about the deaths, yes, of course, it's not always clear what folks are taking. It's not always clear what specific substance or combination of substances has actually caused an overdose death. But one thing is true, that that clearly a patient is at greater risk of death if they are using opioids as opposed to just stimulants, when you compare those two groups. So if we have a patient who is under our care and is using both opioids and stimulants, priority one is to manage that opioid use disorder first. We've got to make sure that we get that patient in evidence-based treatment for OUD, including medications for opioid use disorder, and then we can address the stimulant use disorder. We still would assess them interchangeably and assess them at the same time, but in terms of priority one is the opioids, because that's what's going to more likely than not contribute to a fatal outcome if we're not diligent about that. And then, of course, we want to define patient goals. We may have patients who are only interested in stopping their opioid use, and although we clearly want to help them achieve full abstinence, the fact of the matter is dead people don't recover. So if we can get people on MOUD and get them in treatment for their opioid use disorder, and then we can, and in the process, actually engage them in motivational interviewing and try to encourage them to get into a contingency management treatment process for their use of stimulants, then we've got a chance of helping these patients. And as I mentioned earlier, we have to consider the co-occurring conditions, the co-occurring general mental health conditions, as well as medical conditions that patients may have. So in terms of screening and assessment, I'm not going to spend a lot of time on this. I have a lot of slides, but I'm really just going to go through this quickly because all of this is information that most of you know in terms of making sure you get a good history and physical and diagnosing the OUD and assessing the risk and the acuity and safety of the patient. Again, making sure that we have a good understanding of what's going on with that patient in terms of their use, and also making sure that we can engage that patient in effective harm reduction measures. I'm not going to talk a lot about harm reduction today, but that is really crucial. Harm reduction both in terms of overdose reversal medications as well as safe injection sites and various other harm reduction measures can be crucial. Again, key elements of the initial assessment is that we want to determine the readiness of the patient. We want to make sure that we review the prescription drug monitoring program that we have in the United States. Almost all of the states now have a prescription drug monitoring program. So we want to know what patients are taking, obviously, to the extent that they know what they're taking. And then engage the patient to make sure that they are ready for treatment. We want to assess for other co-occurring medical conditions, including sexually transmitted infections. HIV screening is an important part of this as well. This is a document that I wanted to highlight that ASAM worked on with our sister organization in the United States, the American Academy of Addiction Psychiatry. And it was a clinical practice guideline on the management of stimulant use disorder, and it really has, and I encourage you to visit ASAM's website. You can access this document, download it for free. It is a very helpful document that was published in November of 2023. And so when we're assessing patients for stimulant use disorder, similar priorities, we want to urgently assess the urgency, assess them for possible emergent biomedical or psychiatric conditions, obviously address any acute intoxication. And so I'm going to skip over the rest of this. This is also a very important issue, is the social determinants of health. Housing. Is the patient safe in their environment? Do they have food insecurity? Do they have social support and the availability of peer support? Do they have access to harm reduction resources? Transportation, virtual capability, funding. All of these are important issues to assess because the treatments that we provide may or may not be accessible to our patients if they don't have all of these issues addressed. And then, of course, when it comes to treatment, I think the important thing to remember is that only a small percentage of our patients, of the people who need our help, actually get our help. This is actually 15% that was looked at again by SAMHSA in the National Survey on Drug Use and Health in 2023, but I will share with you also, as you see on the comment on the right, there is a study that just was published in February of this year by the University of British Columbia and by Harvard Medical School, demonstrating that worldwide, that number for patients accessing treatment for mental health conditions and substance use disorder, it's only 7% of those who actually have those conditions access treatment. We all agree that's unacceptable. We all want to work on improving that, but this is something we need to keep in mind. And the various treatment settings are listed here in which we may be able to get a patient into treatment. Office-based opioid treatment is where we will most often be providing buprenorphine treatment for patients. OTPs, opioid treatment programs in the United States, generally refer to the methadone programs that patients have to go to. And I'll take this opportunity to talk about an issue that we at ASAM have been working on and fighting for, and that is that very issue. The fact that a patient has to go to an OTP, an opioid treatment program, in order to be treated with methadone in the U.S. is a problem. That represents a barrier for many people because there are 70% of counties in the United States don't even have one OTP. There are not enough OTPs, and so we really have been pushing to try to make it such that any addiction specialist physician can prescribe methadone to a patient and have it dispensed in a pharmacy. That is not the case currently, and as a result, we do not have adequate treatment for patients who have opioid use disorder at a time when we still, we've seen some numbers come down, but that's still 73,000 people in a year dying from drug overdoses. I think we all would agree is still completely unacceptable, and we still have a lot of work to do. So that is an issue that we've all been advocating for. I've actually appeared in front of the subcommittee of the United States Senate testifying on behalf of this, and various others of our members have also been working on this issue. The piece of legislation that we were working to try to get passed was called MOTAA, M-O-T-A-A, the Modernizing Opioid Treatment Access Act. But at this point, that's with the change in government in the U.S., that is a lot less likely, if not completely unlikely to occur. But we've also been working through other avenues, through the federal government, through the Drug Enforcement Administration. So this is something that's an important issue because it should not be the case that the only way people can get access to methadone is at an opioid treatment program, but that tends to be where it happens nowadays. And also, you see these other settings where we end up meeting up with our patients and giving them access to care. Obviously, the MOUD comparisons of methadone, the full agonist, buprenorphine, the partial agonist, naltrexone, the antagonist, and these are some comparison facts about these, which I won't go into great detail. I want to stop here just to give you an opportunity to ask some questions, but I cannot stop without also mentioning the psychosocial treatments. It is not the case that adequate treatment for OUD or stimulant use disorder or the combination thereof stops with just medication. People have to have effective psychosocial treatments, and in fact, as we know, the treatment of choice for stimulant use disorder is contingency management. And so I'm going to leave it there and give an opportunity for some questions.
Thank you very much, Dr. Taylor. Excellent presentation. So now we're going to have some questions and discussion from the audience. But I first want to ask members of the audience if they have had any experience or opinions about physicians prescribing methadone to pharmacies. In relation to what Dr. Taylor was saying is being proposed and advocated by ASAM. Do we have anybody who can speak to that or ask questions about that? Yes, go ahead.
Yes, thank you for a very good presentation. I'm actually the medical director of 2 OTPs in America, and sometimes the patients coming from Canada and they're prescribed methadone. I think the data for methadone is superb. I mean, throughout the world, in places like India, you just walk in there and they give it to you. They have methadone clinics in Iran, in China, in France. I think you get it every day from the pharmacy. And in Canada, it's prescribed. In America, it's heavily regulated. But wherever you go, I think the data is pretty good. I had a question regarding the co-use of stimulants and opioids. For me, when I looked at the data, to me, opioids and stimulants kill in separate, different ways, totally different ways. Opioids essentially stop your lungs, and then eventually your heart stops because your lungs are not giving it oxygen. Stimulants, whenever you use stimulants, to me, it's a little bit of an unscheduled cardiac stress test. When you do this cardiac stress test, you stimulate the heart rate. What do we do? All these heart rates go up. But now when you mix stimulants with a fentanyl in high levels, what I think might be happening is they could be precipitating coronary artery deaths, and even worse than that, but when they're on have high levels of fentanyl in the system, now it's like having a heart attack and holding your breath at the very same time, which I think maybe, I don't know, I've not seen anything in the literature on this that I think is something we need to look at, because of course, it also works that if you have somebody with a stimulant and with coronary artery disease, that might explain some of the racial disparities you talk about, because as we know, cardiovascular risk is a bigger problem among African Americans. And also, of course, when they have an overdose with a stimulant and you give them Narcan, what happens is the heart rate goes up. And so, I'm wondering why there's no data to look for troponin levels in people who expire with both these substances in their system, to know whether the heart stopped causing them to stop breathing, or they stop breathing causing the heart to stop.
Thank you for that question. That is, first of all, that's a valid point that stimulants and opioids kill in opposite ways, so to speak. That's true. What we found is that a majority of patients who die in a stimulant-involved overdose are people who were also using opioids, who in many cases may not have known. I just showed you some, fentanyl-laced cocaine. So that is a fascinating study, actually. I'd like to see data on that, and I'm not aware of any data on what is it that actually causes the death in those patients. Is it just the fact that the fentanyl is causing death in the same way it normally would, because you're dealing with a patient who may not have the same tolerance to opioids as someone who primarily uses opioids and was intending to use opioids, as opposed to the person who primarily uses stimulants, was thinking that they were just using stimulants, and then got a hold of some that was laced with fentanyl, and they're completely opioid naive. So it could be that, but then again, there are other possible mechanisms. I'm not certain, and I'm not aware of data that's formally looked at the mechanism of death. I think that would be fascinating. I wanted to comment on the first part of your comments regarding people from various other parts of the world outside of the U.S. who do have access to methadone prescribed by physicians, and they're able to access it at pharmacies. I'm not aware that there's that much of a greater problem of overdose deaths or bad outcomes from methadone in those folks, which again underscores the need for us to be able to prescribe it and have patients get it at pharmacies in the U.S., particularly when we have the kinds of numbers I showed you in terms of overdose deaths. One of the things I think we at ASAM were very careful to point out when we were focusing specifically on MODA, now we're looking at other ways to try to accomplish the same goal, is that it is not to the detriment of OTPs. I think physicians who see a patient in a non-OTP setting and feel that that patient isn't stable enough to be prescribed prescribed methadone for their OUD in the office-based setting will absolutely refer that patient to a more structured program like an OTP. And so I think that all it does is it gives more people access to more treatment. I do not believe that it's a matter of physicians outside of OTPs versus OTPs. I don't think that's the issue at all. And so I think that was what your comment highlighted, and I agree with that.
Yeah, it is now. Thank you for the presentation. Clearly, harm reduction is a must. You said people that are dead do not recover. However, I'm wondering what the program or what the plan is after that. I mean, now you have a lot of people in MAT. How do you plan to get them off those medications afterwards? There are people that are staying for years.
That's a great question. What I've always taught people is we need to be clear about what our goals of therapy are. Our goals are long-term recovery and wellness, right? That might be in a person who is on medication for the rest of their lives, as would be the case in a person with insulin-dependent diabetes or hypertension. In other chronic diseases, and of course addiction is a chronic disease, very often people have to stay on a medication, maintained on that medication permanently, and that allows them to live a longer life, as healthy a life as they can when things go well. That should be what we're after with addiction, is long-term recovery and wellness, and whether or not they're on medication is really based on what their needs are. So my view is, I've always used this catchphrase, recovery by any means necessary. I have personally treated folks who have not needed to be on a medication for very long. I've had some folks on buprenorphine, and then after a year, they're doing much better, and they ask to taper off, and they taper off, and they do fine. And then a small percentage of those folks then go through a rough patch, and they're at risk for recurrence of illness. We get them back on the buprenorphine, and they do fine. I've had several people like that. But I've had others who it's very clear they get off of buprenorphine after they've finally been stabilized, they are at risk for death. And it makes no sense to make the goal being off medication when the goal should be long-term recovery and wellness, with or without medication.
Thank you. And then I'm going to turn it over to Mark. But I just wanted to follow up, Steve, on that issue of medication for addiction. So with opiates, of course, there are the opiate substitution treatments, methadone, buprenorphine, and then there's naltrexone. But what about if they have combined opiate and stimulant? Are there medications for the stimulant use disorder part of it?
So that's a great question, and I didn't cover that, and I probably should have. Thank you for that. There are not, in the U.S., FDA-approved medications for treating stimulant use disorder. One of the reasons I showed you that slide that had the cover of our clinical practice guidelines is because that document goes through, in a very systematic way, the evidence that looks at treatment for stimulant use disorder, and has a whole chapter on the medications that have been studied for treatment of stimulant use disorder. The best evidence so far is for a combination of naltrexone and bupropion. The brand name is Wellbutrin, and I say that brand name just to make sure people don't confuse it with buprenorphine, because the names can be confusing. But the combination of bupropion and naltrexone has shown the best efficacy for stimulant use disorder. But it is also the case that sometimes stimulants themselves, the prescription stimulants can actually be effective treatments for some people with stimulant use disorder. That's according to the evidence that the AAAP and ASAM in our clinical practice guideline found. Now, interestingly enough, I don't know how many people were here yesterday, but there was a speaker here yesterday that specifically made the point and showed a slide and everything saying that ISAM's position is that stimulants are not a valid treatment for stimulant use disorder. And I think that is something that is a wonderful example of how we're going to all grow in our knowledge of this. And as we all grow and get more information, as more studies are done and more data is collected, our positions are going to evolve. That clinical practice guideline made it very clear that's the best evidence we have. It is not all the evidence we need. And so I think you will hear different things coming from organizations and from authorities, all of whom are knowledgeable, all of whom should be listened to. But what that points out is that we need more data, we need more research.
Dr. Taylor?
Yeah. So I'll echo some of what Dr. Taylor said with respect to the goal shouldn't be to get off of the medication. It's not like we tell people who have hypertension, when are you going to get off the beta blocker? People are dependent on the beta blocker. They'll go into withdrawal if they stop the beta blocker abruptly, but we don't say, you should be getting off this medication and find a different way of managing your symptoms. I do think in terms of recovery, it's important to give people skills and to address the co-occurring concerns. So a lot of many people with addictions have trauma that often needs to be addressed, many people may have maladaptive coping skills. So if we look at, you had mentioned contingency management is effective while the contingencies are being delivered, but if you take away the contingencies, then people often then have difficulties. So how do we teach people skills that they can then utilize? One of the most durable psychotherapies is cognitive behavioral therapy because it teaches people strategies to cope with cravings, to make different decisions, how to deal with pressures like peer pressures, social pressures, to engage in substance use behaviors. So what we see with contingency management versus cognitive behavioral therapy, we see with cognitive behavioral therapy is arguably the most durable of the therapies that is used for helping people with substance use disorders, where there's even what's called a sleeper effect, where people will continue to improve once the therapy stops because they learn to implement and utilize with greater skill the strategies that they learn. So I think it's important for us to be thinking about the different modalities that we give people, the skills that we give people. And we do this not only from a treatment perspective, but also from a prevention perspective. So Patricia Conrad, going back 10 years or so, looked at imaging data and looked at the factors that were linked to subsequent increases in substance use in developing youth. Genetic factors, brain imaging measures, other scales. What she found was that personality factors explain the most robustly the variance in terms of subsequent substance use. So she developed an intervention program, Preventure, which teaches developing youth skills in acting less impulsively, skills with respect to managing emotional states that are uncomfortable. And she's found when she's implemented this across schools in Canada that it has a significant effect 4 to 5 years later in terms of reducing the level of substance use and substance use problems in youth as compared to the control condition. So I think that there are ways that we can think of how to give people skills that they can utilize as a way of helping them recover, because recovery is not necessarily not using any substance. It's how are you functioning.
Yes, and we're going to get to that young lady just in a minute. But I want to underscore a point that Dr. Taylor made, and that is also the social aspect and the housing, because in the States, often we get somebody into rehabilitation and are successful with getting them on the path toward recovery. But then we have often a discharge issue in the States. Where do you discharge them to? And if the housing is not safe, what happens? They're going to relapse. So there has been an effort looking at that and developing sober housing in the States, but usually that's limited and often inadequate. But I don't know how it is in other countries, but that's a major issue also in relation to recovery. Yes, the young lady over here we have. Do we have a microphone for her?
I have a mic here. Hi.
Oh.
Okay. Yeah. Thanks for an engaging talk, Dr. Taylor. I want to circle back to one of the points you mentioned about in the States how fewer than 70% of the counties don't have access to a clinic. So I run a program called Untangling Addiction. We're really interested in breakthroughs and innovation, and one of the things that we have not seen are breakthroughs or innovations in overcoming that particular barrier, especially as the political climate is shifting in the States. And I wanted to know if what you may be aware of some innovative approaches to try to address that specific issue of how we can increase the number of increase the access to these clinics in different counties.
Well, to be honest with you, one of the things that we at ASAM are doing is trying to address the issue through the federal government. It turns out that there are interpretations of existing laws that have contributed to this barrier of only allowing OTPs to be able to dispense methadone, when in fact those laws probably should be interpreted differently in the first place. But the other thing I have worked in the other part of my career when I was working in pediatrics in mobile units that actually provide care to underserved communities where we take the care to them because we know they're not going to make it to our clinics. And similar things have been tried with respect to providing methadone treatment for people with OUD. It's nowhere near as extensive as it needs to be. There are not enough mobile units. There are nowhere near enough mobile units to address the desert of treatment in so many communities. But that is something that has been used at a small level, and that's the kind of thing that is an innovative practice that needs to be expanded upon.
Thank you. Thank you.
I want to make sure she gets a chance to.
Thank you all. Regarding the earlier question about, in Australia also they do methadone dispensing at pharmacies, but I believe we're going to have a problem in the US if we try doing that. I mean, I've had a problem prescribing more than even one Plan B along with birth control pills. Nobody ever asked me that if I prescribed Viagra, ever. But a pharmacist had a full-on argument with me, which means that somehow or another we have to get together with pharmacists and say, okay, what's going to happen here? The stigma is such that BUP, which was supposed to be part of every family practice office, is not. And 5 zillion people had DEA waivers, and nobody used them. And really, nobody knew how to use them, and nobody really had anybody to call, to figure out how to use them. But the mobile van thing, I think, is very good. The only problem is driving around with controlled substances. I mean, not legally, because that really doesn't bother me as much, but I think, I'd rather not go around with an armed guard. So that's an issue there. And regarding lifelong MAT, as an outpatient doctor, I had somebody who had become addicted to oxycodone after neck surgery, and he'd come way down on his BUP, and he'd use 2 milligrams in the summer and go up to 4 in the winter, and that was his pain medicine, and that was that. And I've also had people who've been on methadone for a very long time, and they're 60 and 70, and they want that 20, 30 milligrams of methadone, which from a brain perspective makes perfect sense. It's not like you're, just to be brief, your chemical imbalance shifts just because you've done this. You can sit on a mountain for 20 years and the chemistry and the neuroanatomy doesn't change, particularly that we know of. Thank you.
Thank you for that comment. I will say there's one huge 5-letter word that we haven't mentioned yet that your comments are basically highlighting, and that is stigma. And that is a huge barrier for all manner of treatment for all of our patients, and that's something that we definitely have to address.
I just wanted to bring up one other thing in terms of accessibility, and that is the use of telehealth. And we saw a great presentation yesterday from Garrett McGovern and about the use of telehealth in rural Ireland. And I can tell you South Carolina in the United States is an extraordinarily conservative state, but we had to relax our rules during COVID-19 to allow more prescribing of controlled substances via telehealth. That whole COVID-19 was an experiment in the United States in the use of telehealth in more liberal ways, and we've published a number of articles actually showing that there was no increase in diversion or overdose deaths or anything as a result of using telehealth for prescribing some of these drugs. So I think that's another way to overcome.
Very good point, Dr. Brady. And in fact, the OTPs are often regulated so that they're prohibited from using telehealth. And I think that there's an interest in advocating for more telehealth with methadone. And I just, before we get to Dr. Bart, I just want to touch on the issue of pharmacies, because that is an issue with MOTA that's being discussed. Well, how do the pharmacies feel? And there's a mixed opinion with pharmacies about whether they want to get involved with dispensing methadone or not. There's different ideas. Some say, well, they should have specialty pharmacies. Others say, no, that it should be, the regular pharmacy should learn how to do this. And that is involved in the discussion and strategy with regard to MOTA, the pharmacies. Dr. Bart, I think you're next.
Bart from United States. So much interesting policy questions. I just have a really basic science question for you, Dr. Potenza. In your imaging slides of delayed discounting, comparing healthy controls, people with cocaine use disorder, and the population on methadone and with a cocaine use disorder, you presented that as co-occurring cocaine and opioid use disorder. But if they were on methadone, wouldn't that be opioid use disorder in remission? And therefore, do you have any imaging that would actually show the co-occurring to see if there are even more impressive differences?
Yeah, so the question was about the co-occurrence of the cocaine use disorder and the opioid use disorder. So the initial slides where it was the healthy controls, the cocaine use disorder, and the cocaine use disorder plus methadone maintenance was the CUD group was without any opioid use disorder. The group with methadone maintenance was the group that was being treated for opioid use disorder, largely not an active problem with opioid use, but people still sometimes relapse while on methadone maintenance. So we don't have people who are actively having problems with cocaine use and opioid use without any treatment. That sample we have not recruited.
So just one last comment and appeal for, well, go ahead. I'll let you, I didn't know we had another question.
Okay, thank you very much. I think the last line is very important in your presentation, that we need to stick to evidence-based treatments. Of course, in the overdose epidemic, the most important is to save people's lives, but this is related not only to access to treatment, but to the quality and effectiveness of opioid agonist treatment. And that would have two parts. One is the proper clinical methodology, adjusting proper dosages, higher dosages to protect people from overdose and to increase retention in treatment. On the other hand, we don't have to miss the human part. I'm surprised that the I got the impression that effective psychological treatments are not properly presented in the integrated approach. And we have enough evidence that motivational interviewing, motivational interventions, cognitive behavioral, integrated in methadone and buprenorphine treatment quite increase the overall effectiveness. So I think that we have to think globally about access, quality, and integration of effective treatments. Thank you very much.
Thank you. And Dr. Taylor, you'll have the last comment before we close the meeting.
Just an appeal to humility. There's so much more that we don't know than there is that we know. And going forward, the way we're going to really address these problems is by learning more. Just an example of why we all need to remain humble. You had a Yale guy up here who misspells heroin in his slides. You have a Harvard guy up here who told you that the word stigma has 5 letters when it actually has 6. So it's just to remind you, none of us is perfect. We all are flawed. We all have a lot more to learn. And so humility needs to rule the day as we go forward. So thank you all for coming.
Yeah, so I obviously need to check my slides. But I would like to echo the important statement about the behavioral therapies. And I do believe that the different behavioral therapies each have a role. The contingency management, I think, particularly in terms of engaging people short-term, motivational interviewing in terms of addressing ambivalence that people often have with respect to entering into treatment and moving through treatment, because oftentimes there are things that people link to the substance use, either from the positive effects, relieving negative effects, or even if it's part of their identity, that are important to consider in the treatment, and motivational interviewing is helpful for that. But I do think that approaches that give people skills like cognitive behavioral therapy are particularly worthwhile to consider. And understanding that what is tested in the academic settings may not translate into clinical practice all that well. So our Psychotherapy Development Center has been involved in implementation approaches, taking what has been tested in research and seeing how well it operates in real-world settings. And oftentimes when people say that they're doing cognitive behavioral therapy, they're not really doing cognitive behavioral therapy. So fidelity of treatment is another important consideration if we are going to be helping people in the ways that we hope to help people. So now we can get back to the conclusion.
Okay, so I think we thank you for your participation. I hope you enjoyed our symposium, and this brings us to a close. So on to the AGM meeting. Thanks.